I will be doing a presentation titled Caring for the Mental Health Needs of Special Populations and Primary Care. The first population of patients that I'm going to be speaking on is the elderly and geriatrics. The prevalence of mental health issues in the elderly community, it usually ranges from 20% of that community suffering from mental health disorders. There are some common conditions involved, including depression, anxiety, dementia, as well as delirium. When discussing economic costs, there's increased hospitalizations, long-term care expenses, as well as societal costs. With societal costs, there are risks of caregiver burden, loss of independence, increased morbidity, as well as mortality. When considering diagnosis and criteria for the DSM-5 overview, depression is persistent sadness, loss of interest, fatigue, and cognitive impairment. Anxiety is about their excessive worry, restlessness, and muscle tension. And with dementia, they have memory loss, confusion, impaired judgment, and personality changes. Some assessment tools used are the Geriatric Depression Scale, which is a 15-item questionnaire for depression screening, and a mini mental state examination, which is a 30-point questionnaire to assess cognitive function. And some considerations are differentiating between normal aging and pathological cognitive decline. This is because of the elderly population often having some decline only due to their age and not from mental health issues. Considering pharmacological interventions for some of the treatment plans, we have antidepressants such as SSRIs, antipsychotics, and for dementia-related agitation, and then cholinesterase inhibitors for Alzheimer's. Lab testing is required before the starting of these medications, as some baseline labs are needed, such as CBCs and liver function tests, sometimes even the EKG. With kinetics and dynamics, drug metabolism in the elderly, and also there are risks for polypharmacy, which is also important to consider because of their other disease processes they may be dealing with. There's always a risk of a medication, and sometimes patients having too many medications that they're taking, and to consider some of the contraindications and how some of the medications work with each other. When considering psychotherapeutic options, there are some such as cognitive behavioral therapy, family therapy, and then also lifestyle modifications. Even if it's something simple as changing their diet or having a sedentary lifestyle or isolated lifestyle. And then there are collaborative interventions such as the involvement of geriatricians and neurologists as well as social workers. The next population of patients is perinatal and lactation. Epidemiology-wise, prevalence, 10 to 20% of women actually experience postpartum depression, and also anxiety disorders are common. Some of these conditions include postpartum depression, anxiety, and postpartum psychosis as well. When it comes to economic costs, maternal mental health affects child development and family dynamics, and increased healthcare utilization, long-term developmental issues in children. For risk factors, there are hormonal changes, history of mental illness, and then also lack of support. As we all know, support is very important when it comes to a pregnant female. Diagnosis and criteria for this population, DSM-5 overview for postpartum depression. It consists of a depressed mood, having loss of interest, feeling worthlessness, impaired functioning, and it occurs within 4 weeks of the woman being postpartum. For anxiety disorders, that's of course again excessive worry, having panic disorders, and obsessive compulsive symptoms. And then postpartum psychosis consists of the patient having hallucinations, delusions, severe mood swings, confusion, and this can be an emergency condition. This is an emergency condition. For assessment tools, um, clinicians and physicians use the Edinburgh Postnatal Depression Scale. And some considerations are distinguishing between baby blues and clinical depression, because most women will have some form of baby blues, which can subside, while others may actually have more serious issues like postpartum depression. And then considering the impact of pregnancy and lactation on mental health symptoms. The treatment plan for this population, of course, again, you have pharmacological interventions such as antidepressants. Of course, it's important to determine that they're safe for breastfeeding and hormonal therapies. And then lab testing is required to obtain labs that are giving us the base values for the patients as well when it comes to the antidepressants, not only for therapeutic reasons, but also because of medications that can be transferred to the patient, to the baby through breast milk, which is also discussed with kinetics and dynamics. Medication can be transferred through breast milk, so it's important to understand that when it comes to the timing of administration of medicine, as well as the timing of when moms breastfeed. For psychotherapeutic options, you have interpersonal therapy, group therapy, and mother-baby bonding interventions. And then we have collaborative approaches such as involvement of obstetricians, pediatricians, and lactation consultants. The next population to be discussed is the pediatric and adolescent population. It's very common for the population to have mental health issues, some including ADHD, depression, and anxiety. The prevalence of anxiety, depression, ADHD, and conduct disorders in children are 1 in every 5. For economic costs, there is an impact on education, family dynamics, as well as long-term societal costs. Some risk factors include family history, trauma, and the patient's social environment. For diagnosis and criteria, for DSM-5 overview, the ADHD, there's inattention, hyperactivity, impulsivity present before age 12, and then impaired daily functioning. And then for anxiety disorders, there is excessive fear or worry, often related to school or their social situations. And then there's depression, which is persistent sadness, irritability. They feel withdrawn, and they have changes in their appetite often. Is very common in this population. A lot of times there are even eating disorders. Some assessment tools to utilize are child behavior checklists as well as ADHD rating scale. And some considerations are the development, excuse me, I'm sorry, the child's developmental stage and the impact of family dynamics. And this is important and significant as sometimes a child may be in a stage of their life where some of the actions are common versus it actually being a mental disorder. All right, some forms of treatment for this population include pharmacological interventions such as stimulants for ADHD, SSRIs for depression and anxiety. And of course, again, we need the baseline lab testing before starting these medications. And then the kinetics and dynamics, you have to make sure that the clinicians consider the age-related metabolism, as some medications metabolize faster or slower in certain age groups, and then the impact on the child's growth and development, as some medications may stop their growth or slow their growth down. So that's very important to consider. And then for psychotherapeutic options, we have play therapy, family therapy, school-based interventions as well. And then some collaborative interventions include pediatricians, school counselors, and family therapy. The next population to be discussed is the LGBT community. With overview, the mental health issues in the LGBT populations include higher rates of depression, anxiety, and even substance abuse. Epidemiology-wise, the prevalence of depression, anxiety, and suicidal ideation in these populations are very common. There are some economic cost issues as well. LGBT individuals also often face barriers to accessing care. Societal costs and issues involve the stigmas. There are a lot of discrimination, even amongst providers, and minority stress contribute to poor mental health outcomes. Some risk factors involve this discrimination, the minority stress, and then the lack of support that many of them face. For diagnosis and criteria, DSM-5 overview, depression and anxiety, same criteria as for general population, but often exacerbated by minority stress, gender dysphoria, incongruence between experienced and expressed gender and assigned gender, which also causes distress. And then some assessment tools used in this population include you have to be inclusive with these screening tools and very gender sensitive when diagnostic. Some type of considerations included the importance of affirming care and addressing internalized stigmas. Forms of treatment for this population also includes antidepressants and anxiolytics and hormone therapy considerations, as some patients do want to take hormone pills because they do want to change their physical appearance. So it's important to understand that. And lab testing, again, is very, very substantial, not only for the hormone thing therapy, but also for the antidepressants and other medications. When considering kinetics and dynamics, we must always consider the hormone therapy on medication and how it impacts the patient itself and other medications they're taking and their metabolism. For psychotherapeutic options, we have affirmative therapy, cognitive behavioral therapy, and group therapy. And some collaborative interventions include the involvement of endocrinologists, mental health specialists, and support groups. So next is immigrant and migrant workers. For epidemiology, they have high rates of PTSD, depression, and anxiety, particularly among those that have been exposed to trauma. With economic costs, we have the healthcare utilization, which is often not utilized due to the barriers such as language and cultural differences. And then you have risk factors such as trauma, acculturation stress, language barriers. Mental health challenges faced by immigrants and migrants include trauma, PTSD, and depression. But the diagnosis and criteria for DSM overview, PTSD is re-experiencing, of course, is avoidance and hyperarousal following a traumatic event. This is often seen with immigrants. And depression and anxiety, they have common symptoms, often exacerbated by stress related to the migration and their acculturation. Some assessment tools used are you have to be culturally adapted with the screening tool. So the provider should know exactly what they're doing before they even try to use the screening tool. They should have utilized it before or at least have done some research. And you also have to be very language sensitive when it comes to diagnosing as well. Some considerations, impact on cultural background and symptom presentation. When considering treatment plans, of course, pharmacological interventions as well, antidepressants, anxiolytics, PTSD specific medications, and again, lab testing to get baseline labs on that patient, not only in the beginning, but through the medication taking process. For kinetics and dynamics, considerations of traditional medication interaction. And for psychotherapeutic options, trauma informed care, and be culturally sensitive for therapy. Um, Collaborative interventions include involvement of cultural mediators, community health workers, and then also legal support, which is very important. When the next section is ethnic minority groups, mental health disparities among specific ethnic groups, such as Hispanics and African Americans, economic costs, the impact on community health, their access to care, as well as healthcare utilization. Some risk factors include socioeconomic factors, being discriminated against, and again, cultural stigma. For diagnosis and criteria, ethnic minority groups include cultural adaptive criteria, which is considering cultural expressions of distress and the role of cultural content in diagnosis. Common disorders include depression, anxiety, PTSD with considerations for culturally specific symptoms. Syndromes. And then assessment tools have to be culturally appropriate and they need to consider the cultural expressions of distress. And considerations also include impact of cultural beliefs on diagnosis and treatment adherence. So we have to make sure that we understand what this particular cultural patients feel, how they feel about diagnostics, how they feel about treatment, how they feel about adherence to medications, adherence to therapies, whatever form of treatment is recommended for this patient. And treatment plans include pharmacological interventions, medication preferences, cultural considerations, and prescribing. Kinetics and dynamics, you have to consider genetic variations such as the CYP450 gene, which is often common in a lot of patients, and you have to make sure that that isn't present. So that's why it's important, like I said, to do some lab work a lot of times before any type of prescribing is done at all with any patients because it does affect the metabolism of medication depending on what genes they have present. Psychotherapeutic options conclude culturally adapted cognitive behavioral therapy and community-based interventions. For collaborative interventions, this could include in the involvement of cultural leaders, community organizations, and the support of family, which is very important for no matter what the population is. Family support is always substantial. Conclusion, caring for mental health needs of special populations and primary care is essential to recognize the unique challenges and vulnerabilities that each group faces. whether elderly, perinatal, lactating women, children and adolescents, LGBTQ individuals, immigrants and migrant workers, and ethnic minority groups. They all require tailored approaches that consider their culture, the developmental, and the contextual factors involved with this patient. Thank you. Next will be the reference.